So as more and more clinical evidence is being generated, we've now started moving towards below the ankle angioplasty. And this is more so in terms with the Woundosome concept. And we've started moving towards more wound targeted revascularization. So this case is to highlight the same concept. So when it comes to below ankle anatomy, there are three major arteries supplying the foot. One is the anterior tibial artery. Now the ATA continues at the dorsalis pedis artery and supplies the dorsal aspect of the foot. The plantar aspect is predominantly supplied by the posterior tibial artery with its two branches, the lateral and the medial plantar arch. And it's the peroneal artery which can have dominance and can supply collaterals and supply either the dorsal or the plantar aspect. Now, anastomotic communications or collaterals exist between the plantar and the dorsal supply, and three main anastomotic collateral channels exist. When it comes to these three anastomotic channels, basically the first one is the anastomosis between the arcuate artery, which is a branch of the dorsalis pedis artery, which forms a collateral network with the lateral tarsal artery, again a branch of the DPA itself, and this supplies the dorsal aspect of the foot. The second important anastomosis is that between the medial plantar arch. Now the medial plantar arch is a branch of the posterior tibial artery, and this will anastomose with the first dorsal metatarsal artery, which is a branch of the DPA, and this is the predominant supply to the great toe. The one that we are most commonly aware about, and that is the plantar arch. Now this is the anastomosis between the lateral plantar artery, which is a branch of the PTA, and the deep plantar branch of the dorsalis. This forms the plantar arch or the pedal plantar loop, and this supplies the second to the fifth toe, both the dorsal as well as the plantar aspects of these toes. So this is the anatomical representation of the three discussed anastomotic networks. The one in green is the anastomosis between the lateral tarsal artery and the arcuate artery, supplying the superficial dorsum of the foot. The one in red is the supply to the great toe, which is between the first dorsal metatarsal artery of the DPA and the medial plantar artery. And the one in blue is the plantar arch, which is basically between the DPA or the deep palmar arch of the DPA and the lateral plantar artery of the posterior tibial artery, which eventually supplies the second to fifth toe. Again, this is the expected location of these collateral networks on the anterior posterior projection and the corresponding DSA image. Like seen in the earlier anatomical image as well, the one in green is the anastomosis between the arcuate artery and the lateral tarsal artery. The one in red is the supply to the great toe between the medial plantar artery and the first dorsal metatarsal artery. And the one in blue is the plantar arch between the lateral plantar artery and the deep plantar branch of the dorsalis pedis artery, supplying the second to fifth toe. So most of the revascularization that we are doing below the ankle is now based on the Woundosome concept and not on the angiosome concept, where it's better to revascularize and provide a straight line direct flow to the wound by opening one of the arteries described above. So coming back to the case in point, we had a 62-year-old male with critical limb ischemia. He had a great toe wound. This was non-healing with blackening of the wound. He was posted for a peripheral angiography followed by revascularization. The angio was done, which showed good flow in the main trunks of the anterior tibial artery, the posterior tibial artery, good flow up to the ankle. And we did an AP and a lateral view, and below the ankle, the dorsalis pedis was normal. However, there was complete CTO of both the medial and the lateral plantar arch. So this is the DSA images of the foot in the AP as well as the lateral. The starred area in red is the area of the wound, which is in the region of the great toe. And the dorsalis pedis is normal, but there is complete CTO of both the medial as well as the lateral plantar artery. So based on the Woundosome concept, we need to provide a single straight line flow to the great toe. So two options: either we open up the lateral plantar artery and the pedal plantar loop, which is what we commonly do, or we go ahead and open up the medial plantar artery, which has an anastomotic collateral with the first dorsal metatarsal artery. So this is again the image showing the crossing of the medial plantar artery, and then we opened up and we almost went up to the first dorsal metatarsal artery. You can see the wire parked in the dorsalis pedis artery, and we did a plasty with a long 2 millimeter balloon. So again, these are the pre and the post images. The one on the left showing the 3 anastomotic collateral channels which were seen on the first image, the one in green, red and blue, and because it's the region of the great toe, we went ahead and opened up the medial plantar artery. Again, the anterior posterior images in DSA showing up the opening of the medial plantar artery with the collateral network with the first dorsal metatarsal artery, and thus a direct straight line flow to the great toe. Again, the pre and the post images, the one on the left showing the region of the great toe with the wound and blackening, and the patient ultimately went for a great toe stump amputation, but good blood flow and table on both the dorsal as well as the plantar aspect of the great toe. So key points is that we've started doing more and more below the ankle angioplasties, and our revascularization is based on the Woundosome concept. This is an emerging factor determining overall wound healing and reducing the rates of amputation. So we would like to provide a single straight line flow to the wound based on this concept. Important to be aware about the anatomy and the existing collateral channels between the dorsal aspect of the foot, which is supplied by the DPA, and the plantar aspect, which is supplied by the PTA. And based on these collateral anastomotic channels and the wound, it's better to have a target revascularization in the region of the wound. Of course, it's important to know that anatomical variations are known. Example, at times there would either be a plantar dominance or a dorsal dominance, and sometimes there may be a complete absence of the pedal plantar loop and no anastomosis between the dorsal and the plantar aspect as well.